Recording. Okay. So hopefully today we don't have a repeat of yesterday and freezing of the screen and things like that, right? So we'll start from fresh. Okay. So there's a few reasons why you need to look at the soft tissue of the neck. All right. Number one, soft tissue of the neck tells you about infections in the neck. It tells you about injuries in the neck. It tells you about injuries to the structures. So what travels through the neck? All of your important structures travel through the neck, all right? So it's the connection between your CPU and the rest of the computer, all right? If you understand what I mean, all right? That's your CPU, your central processing unit sits here at the top, and basically everything else then is connected to it via the neck. So you've got your spinal column, with your spinal cord, you've got a lot of your major vessels, all right? You've got your esophagus, so you can intake food, and trachea, so you can take in air, all right? So any of those can be injured. So what happens is we've been looking at the bone specifically, but that's not the whole neck. So what happens when something else is affected? That's what we're trying to say today, okay? So that's what we're going to have a look at. And we're not going to cover it in, you can see what you share. Okay, I don't know what that means. Let's have a look and see. So the first thing we need to know is we just need to know the normal anatomy. Right? Can you guys see over there? This thing is not moving anyway, so it doesn't make a difference. All right. So we'll cover the distances just now, right? But these are just the normal distances. But I'll show you the exacts in a little while. The more important thing is to understand what you're looking at. So we know we've learned about the C-span, C1, C2, C3, C4, C5, C6, C7, T1, all right? So this, what you're seeing is the pharynx, okay? Then this that you're seeing, this little structure over here, that's the epiglottis, all right? What looks like somebody hitchhiking, okay? Like a thumb almost, right? So that's your epiglottis, your hyoid bone, although we don't worry about it too much, and it has to be quite a specific X-ray to look at the hyoid, all right? The epiglottic folds, which we don't stress about too much. So the epiglottis, like I was saying, if you guys have intubated, then you know what the epiglottis looks like, all right? Because that's what you lift out of the way to be able to see your larynx, all right? And your vocal cords and things like that. So the structure that is visible, so to speak, is the trachea. And behind that is the esophagus. So your esophagus you can't see really well, and your trachea you can see. Any idea why? Yes, it's a common thing with X-rays, all right? So how does an X-ray work? An X-ray is a fancy way of saying a photon, all right? So what they call X-rays were actually photons. So you're shooting off a photon. So a photon can just pass through your body. That's the whole point of it, all right? So when it passes through your body, if it hits something solid like a bone, it gets stopped, all right? So the film that's at the back doesn't get the photon, all right? So it creates an image like that. If it hits something semi-solid, like a liquid or something like that, then you may get a slightly lighter shade, but it still can't pass through. And when it hits air, it can go through completely. So when it hits the film, it turns the film dark. All right. So that's how X-rays function. Okay. So these are your normal structures. So just kind of remember this. Okay. Well, like I said, we'll get back to the distances in a little while. All right. And we're going to have a look at some of the conditions that you need to look at, right? Specifically to try and understand what could be going on. Now, like I say, it's not comprehensive. I can't teach you everything to do with soft tissue of the neck because we'll be sitting here for the next 3 days talking about that. So we're going to cover some of the more common ones, right? So let's talk first about croup, LTB, laryngeal bronchitis. Have any of you seen a kid with croup? You should have if you went through pediatrics, all right? So one of the typical things of them is barking cough, all right? So you hear like that, you know, literally it sounds like a dog that's barking, you know. So it's a viral infection and the children tend to get stried up, right? Now the reason for that is with this viral infection, they basically get a lot of edema around that larynx and trachea, right? So the way that that presents is a narrowing. Now let's have a look here at this X-ray, all right? So let's look at the norm, then we look at the abnormal. So here we can see our pharynx. We can see it coming towards our epiglottis over here. Can you come through it, right? I don't think there is anything. No, there's nothing there. All right. So then what happens is when you come down and you follow your esophagus over there and you follow your trachea, can you see that? All right. Let's look at it from this side as well. Can you see that? Quite severe narrowing. All right. So there's not much air that can get through that. Okay. So this is called the steeple sign. All right. The reason why it's called a steeple sign is that the steeples in a church look like that. All right. So the tower, and then the steeple, the point at the top, right? So that's why it's called the steeple sign. You don't have to remember the name of it. I'm just explaining to you what it is, all right? So this narrowing is what's causing the problem. Got it. Okay. So essentially the child can't breathe through there. Okay. So they become more and more desaturated. They have worse and worse respiratory distress. Eventually they start dropping their saturation. So it's like any patient who has any sort of respiratory illness, even our COVID patients, all of them. So initially what happens is the patient is restless, tachycardic, BPs may be going up, things like that because of anxiety, increased effort of breathing. And then as they go on, they become more and more hypoxic. So they become more and more limp. And with kids, it tends to happen much more quickly. So they become limp, they become lethargic, eventually they become what we call completely hypoxic, bradycardic, things like that, right? So croup is not something to mess around with, okay? I wonder when all of you have kids as well, as soon as you hear there's a barking cough, yeah, I mean, don't rush them to ICU, but what I mean is get treatment, as quickly as possible, right? So the question is, what is the treatment for croup? And the treatment is adrenaline nebulization, all right? That's it. You just nebulize them with adrenaline. It's a viral infection, right? So why does adrenaline work? Adrenaline works because adrenaline is a vasoconstrictor. Okay, so as soon as that adrenaline hits that edematous patch, it causes vasoconstriction. There's no reason for the edema to be there anymore. So the edema kind of retracts a little bit and you get an opening of the airway. Okay, so what happens if you can't, if it's gone really, really far? Can you intubate these kids? Can't really intubate them. So what do? Cut open, stick it in. All right. Now with kiddies, of course, you can do needle tracheostomies and things like that. It depends on the age. It's not something you should just attempt to do. There's a lot of technicalities with children and surgical airways, but I'm just telling you that's more or less what you have to do. All right. But luckily, if the child is already at that stage, the child will probably not, or not luckily, it's a bad thing, but I mean, the child won't make it to hospital if they're at that stage already. Okay. Generally, unless this child is very neglected, the parents will have brought the child to hospital before that. So 99% of them, you will give them adrenaline nebulization. They will start settling down. They still need to be in hospital. They need to be given what you call steroid therapy and adrenaline nebs, and that's the thing. All right. But the more important thing is just to note what we're looking at. Okay. So let's go to another one. Okay. So what's the first thing? Let's not worry about this part. Okay. Let's just look at the X-ray itself. So what's the first thing that you notice? Where's everything? Yes, very good. So it's been moved very far away. Okay, even if you don't know the exact distances and things like that, which we'll get to in a second, the most important thing is that everything's been pushed away from the spinal cord. All right. So here we have our pharynx. Here we have our epiglottis over there. Yeah. And then we get into our trachea and our esophagus over here. So you can see the trachea is not involved. What do we see that looks strange, however? There are some things that look odd over there. What is this? I mean, is that a normal thing that we saw in our normal X-ray? All right, so what is this? Yeah, very good. So there's gas formation. All right, so what forms gas in tissues? Infections. What type of infections? Anaerobic infections. All right, so anaerobic infections give you gas. Okay, so we need to already know that we're dealing with an anaerobic organism, right? 99% of it. Okay, what's the other thing that we notice on this X-ray? Because we all love to look at the big flashing red light and we forget about other things. So still look at your C-spine. All right, what do you notice about the C-spine? Absolutely straight. Okay, the reason for that, maybe muscular spasm, simple swelling in itself, right? Doesn't mean this patient's also developed a fracture over here. Don't stress. But what I'm saying is, look at everything. Don't just now, yay, I found the problem, so I'm gonna stop there. No, you must look at everything because you may find other things. All right. So what is this? This is a retropharyngeal abscess. Okay, retropharyngeal abscess. Also very common in, more common in children. All right. The bad part about retropharyngeal abscesses, these patients come in toxic. Okay, so it often starts as a small upper respiratory tract infection, maybe a bit of tonsillitis, adenoiditis, pharyngitis, things like that. And as with any infection, there's a reason. Maybe there's a pre-existing injury, pre-existing damage, or just excoriation of the epithelial lining. So this anaerobe is now allowed to pass further down into the further tissue planes and starts to form abscess coloration. Okay, so because of the full ringtone, so these are sick patients. All right. So by the time they come to you, they are toxic, majority of the time. All right. The main thing that these children have is drooling. They have pain in their throats, but because it's mimicking tonsillitis, if I put it that way, even GPs, people who may see the patient initially, give them antibiotics, try these analgesics, it may be viral. So generally when these kids come, they're already quite sick. Now they've got a significant swelling, they can't swallow, they can't talk, they can't do anything, and they just fevers above 40, they lump, things like that. And like I say, it can mimic meningitis as well. So it can mimic meningitis, right? So you get knuckle rigidity, things like that, all right? And generally there's a preceding pharyngeal infection, all right? So the main thing that you will see is this, all right? This movement of the entire soft tissue plane forward, because it's the, collection that's sitting behind. So what are you going to do for this patient when this patient comes in? How are you going to treat this? Please don't say adrenaline nebs, eh? Okay. So here we have a look at the distances that we're normally supposed to see, all right? So between C2 and C4, we're supposed to see 1/3 of the vertebral body. That's normal. So we'll go back, and from C4 downwards, it should be 1-to-1 width of the vertebral body. So that's what we're talking about in this one here. So in other words, C2, C3, C4, you look at the vertebral body, and 1/3 of the width is the normal space, all right? And then the rest of them, C4 downwards, you look at the actual size of the vertebral body, and that's how far the trachea should be in front. Okay, all right. So getting back to this one, you can easily see that they're well beyond those. Okay, so like we said, we noted the wider spaces, we note the gas buildup in the soft tissue. So these patients require urgent CT to define the abscess and see how bad it is, and then surgical or ENT intervention. All right, so ideally ENT. But if worse comes to worse, a general surgeon can also manage a retropharyngeal abscess. Okay, so if worse comes to worse, this is just for interest sake. Now you don't have to know. Just through an oral approach, a general surgeon can access this pouch and at least drain some of the abscess out. But they can't actually completely incise and drain it. So normally with the ENTs, they use a lateral approach. By the sternocleidomastoid, push everything out of the way, then into that pouch, completely, drain it, remove the epithelial line. So it's not a small thing. It's quite a major operation to actually get it sorted out. Okay, right. So what is this? I know it's not an X-ray of the neck, sorry, but just want you guys to just kind of have a look and see what's going on. Very good. It could be epiglottitis. Could be a mumps. All right. Okay, so first, where's your epiglottis? Your epiglottis is here. Where's the problem? Here. So it's not your epiglottis. So it's not epiglottitis. Where's your parotids? Parotids. You said mumps. Yeah, parotids. Like, geez, man, what anatomy did you do? Look at the patient. Right. So where's the problem? Is it here on the side or is it at the front? It's towards the front and underneath. Right. So even if you don't know what the diagnosis is, are you worried? Why are you worried? Very good. The airway is compromised in this patient. All right. Where does the problem seem to be coming from? Is it the tongue or is it below the tongue? Below the tongue. Very good. Because if you look at the actual tongue, the tongue looks fine. All right. So yesterday we had our patient with angioedema. So the problem with angioedema is the tongue. You know, the tongue swells up. But in this one, you can see the tongue is normal, but it looks like the floor of the mouth. All right. And the floor over here. Okay. So this is called Ludwig's angina. Ludwig's angina. All right. Now, why I brought this one up is even though it doesn't have much to do with soft tissue X-rays, but simply because we see a lot of these in pediatric patients and adult patients as well. All right. So what is Ludwig's angina? Morbus strangulatorius, which you can put as a differential diagnosis, I suppose, and confuse the hell out of the surgeon. But rather put Ludwig's angina. All right. So what is it? Number one, it's a cellulitis. Not an abscess of the submandibular space. Sorry, I'm just going to mute my phone over there. You can just hear what's happening in the back. All right. So it's a cellulitis, not an abscess of the submandibular space. All right. The cellulitis involves all of the sublingual, bilateral submaxillary spaces. We'll get back to that now. The cellulitis produces a serosanguinous putrid infiltration, but very little or no frank pus. All right. Now I'm going to get back to why I'm going through all this. Fascia, muscle, connective tissue involvement, it's very dense, and the cellulitis is spread by continuity and not by lymphatics. All right. So that's a nice way of them basically describing it. But what we're talking about here, and like I say, the reason why I brought it up, we generally see in our A&E, I see about 15 to 20 of these patients a year, right, with Ludwig's angina. And the spread is, it tends towards the younger patients, but we have had quite a few older patients as well, especially those with poorly controlled HIV, right, low CD4 counts. They're also quite prone to getting Ludwig's angina. So what happens with Ludwig's angina is that you start getting a cellulitis at the floor of the mouth. All right, for whatever reason, it may be an bacterial viral entry via the mandibular ducts, things like that. So as soon as it gets in, you start getting this swelling. All right, that occurs. Now, a lot of people, the reason why I mentioned it's cellulitis and not pus, a lot of people feel that if you cut this thing open, everything's fine. No, actually, it doesn't respond very well to cutting because there's hardly any pus. The main problem is the swelling. All right, so let's go back just one more. I just want you guys just to have a look at this. So I just want to get back to the normal X-ray. So basically, this is where the swelling is starting. All right, in the bottom over there. There's not much space for everything. All right, as they say, it's not spread by lymphatics, it's spread by continuity. So in other words, it's only spreading along these tissue planes, whereas with lymphatics, it would pass along to the cervical chains and things like that. So what's sitting above it is the tongue. Okay, and as the swelling gets worse and worse, the tongue gets pushed up and up and up and up. So if you don't do anything for these patients, eventually they cannot breathe. So they just quite simply suffocate to death. All right, now actually there's not much to see on an X-ray. So I'm sorry I introduced it here. It was just, it seemed appropriate because it's neck that we're talking about, right? And because we see so many of these patients. So what do you do for these patients? How do you treat cellulitis? Antibiotics, very good. How do you treat swelling? Anti-inflammatory, steroids, things like that, right? But where do you treat this patient? Very good, exactly. So you do not send this patient home. That's what I'm trying to say, all right? So once you see this, all right, it's very tempting to say, oh, but it's just a little swelling, you can go home. I mean, if somebody could have a dental abscess on this side, that's what you'd do. You'd give them Augmentin or Moxil, Panado, Brufen, and go home. But simply because of the location, you do not do that. Because if you do, you have sentenced your patient to death, all right? Because they will get worse and worse and worse and eventually push their tongue up. And that's it, patient demises, okay? They cannot breathe, okay? So when your patient comes in late stage Ludwig's angina, again, no access to the airway, you're talking about surgical intervention to get an airway. So it's not something you want to do. You get what I mean? How many of you have done a surgical airway? It's not fun, I can tell you that much, having done a few now, all right? Even now, that's one of the few things that if you had to check my heart rate while I'm doing it, you'll see suddenly my heart rate is 130, 140, 130, 140. Simply because it's a simple procedure, but it has the potential for a lot of complications, all right? Aspiration of blood, cracking of the hyoid, cracking of the cricoid. You know, if you, and because it's done in an emergency setting, you don't have time to suction and look and get the right light and make sure you've got the perfect retracted. No. You're just cutting and going. And you never know, have I done everything correctly? Because if I haven't, you've now caused that patient to have many months of treatment thereafter. For example, a cracked hyoid, a cracked cricoid is not going to just repair itself. You need an ENT in there. But again, even an ENT will tell you, I can treat a cracked cricoid, I can't treat a dead patient. So it's fine. You rather save the patient, it's okay. But what I'm saying is it has that potential. So you don't want your patients to get to that point, if you get what I mean, all right? Sometimes we have to, but we don't want it, all right? So about the most thing that you may see, and it's not an X-ray diagnosis, but you can see gas again, all right? But remember, whenever you see gas, there is an organism, generally an anaerobic organism. Okay, so always remember that. This is just a CT of the same thing, all right? And if you can't see the tongue too well here, but if I brought it a bit forward, then you could have seen it, okay? All right, so this is epiglottitis, right? So it's just cut off there at the top, okay? So when we look at the X-ray, what do you notice about the epiglottis compared to the one that we saw before? Considering this is a normal one. Yeah, very good. What does it look like? Yeah, now it really looks like a thumb. So this is the proper hitchhiker's sign, all right? So this one here, not so much. Oops, sorry. Go back. So when you see this, that's epiglottitis, okay? So what do we notice? Number one, the distances are fine. Everything else is okay. Even if you look at the trachea, the esophagus, everything's okay. It's only the epiglottis. Okay. So the X-ray basically is confirming a clinical suspicion. All right. So how do you know what's happening? Epiglottitis, and this is very true, rapidly progressive, life-threatening inflammation of the supraglottic larynx. Why is it life-threatening? Very good, because there's your airway just here. So as it gets bigger, it's just cutting off your airway. All right. And the thing is, the epiglottis is not a large structure. So when it swells up quickly, and it swells up to a large extent, and it can block off everything, because you're not talking about a lot of space in your neck. All right. So remember that. Okay. So it becomes more prevalent with the rise of the anti-vaxxer movement, which is true, right? Because it's caused by Haemophilus influenza B. So how many of you are anti-vaxxers here? Very good. Okay. No, I'm being serious. All right. We all know that the movement is out there. Are you an anti-vaxxer? Yeah, no, that's fine. Did you take the COVID vaccine? So you're an anti-vaxxer. All right, very good. All right. So, no, what I'm saying is it's relatively easy to prevent, but we're seeing more and more of these patients coming. All right. So what happens? You get generally a sick child, toxic. So what do we mean when we say toxic? What are you talking about? Patient with extremely high temperatures, tachycardic, signs of septic shock. All right, so that's what we say when we say toxic. The child is limp, the child is lethargic, the child is sick, extremely sick. But it can occur in adults as well, but this is much more common in children. All right, inability to swallow for obvious reasons, stridor for obvious reasons, all right, and drooling because of the inability to swallow. Okay, so if you get a sick child with no other obvious things, but you got drooling, you know you've got to do a soft tissue of the neck. If there's stridor, you need to do a soft tissue of the neck, regardless of whether it's adult or child. Okay, so just remember that. Okay, and now you know what to look for. So if you just glance at this X-ray, you easily miss this. So look at each segment so that you know what you're going to find. How are you going to treat this patient? Antibiotics, steroids, and if worse comes to worse, intubation. All right. Do you think it's going to be an easy intubation? Are you going to do it? No, you're going to ask the most senior person. All right. Unless you're stuck in like East Fontaine where there's nobody else and you just have to do it, you do it. So what happens if you can't lift that epiglottis? Yeah, very good. You've got to cut down there and get into there. All right. So better to treat early and vaccinate your kids. All right. Good. All right. So this is a button battery. We've all seen these kids. Agreed. Should I be worried for a button battery? Would you be worried? Why should you be worried? Should you work quickly, or can you send the patient away and come back and do things like that? Occlusion is just one part of it, right? So I also included this simply because this is one of those things, again, that's not really taught to us in medical school, but has a potential. And you see, you're nodding because you've got kids, so you've seen all the articles on it as well, right? So button batteries, of course, they have the potential for just straightforward occlusion, right? But that's actually not very common because they're quite thin, they're quite small and things like that. So when they tend to get stuck, it's like any sort of a 2-rand coin or 5-rand coin. It just kind of gets stuck there, but there's still space, for air and things like that to get through. So the question is, why is it worrying? So I'm going to show you guys now why it's worrying. All right, so we're just going to see what problems it can cause, okay?
Despite their small size, button batteries can carry a potent charge. If swallowed, a lithium button battery may travel through the throat, stomach, and intestines with no issues, but beware. Swallowed button batteries can cause serious injury. They can even be deadly. There have been many cases of button batteries becoming lodged in children's throats and causing burns. It can happen as quickly as 1 hour after being swallowed. A button battery can cause damage in 3 ways. First, it can create electrical current. Second, it can put pressure on sensitive tissues. And third, it can leak harmful chemicals from the battery. And all of these can cause burns to the throat or the stomach. The burn can be so intense after only several hours of exposure that the voice box can be destroyed or internal bleeding can occur. If you think a child may have swallowed a button battery, call the poison center right away. it may be important to take the child to a hospital to get checked out. Early symptoms after swallowing a button battery can be mild, things like a sore throat, trouble swallowing, a little cough, but as the battery remains stuck, it can continue to cause significant damage, leading to even more severe symptoms such as trouble breathing, abdominal pain, chest pain, bloody vomiting, and shock. This damage can be permanent, leading to the inability to eat through the mouth or to speak, and unfortunately, death has been reported following button battery ingestions. If you look, you'll probably find you have button batteries in your home right now. Button batteries can be found in everyday items such as greeting cards, remote controls, bathroom scales, digital thermometers, cameras, calculators, and lots of other electronics. If you have children, it's a good idea to avoid buying things with button batteries if you can. If you have products containing button batteries, especially those that can be accessed without a screwdriver, they should be stored out of reach of children. And never leave loose button batteries lying around accessible to young children. And never use your mouth to hold a button battery. Accidental ingestions of batteries can occur in adults too. Now remember, if you or someone you love swallows a battery, call the poison.
Okay. So you can see what problems it causes. Okay. So the electrical charge is relatively common, but even more common than that is the acid leakage, or the lithium leakage. What happens is as soon as the battery gets inside, because of the way that they are constructed, there's a very quick oxidization that takes place of the capsule, basically the metal that's contained in the battery. So the combination of the saliva plus the, what is it, the particular enzyme that we have in our saliva, so that also causes breakdown that's quite quick. Right? So basically, if it goes down into the tummy and into the rest of the alimentary tract, you can watch it pass. There's no problem. If it's stuck in the tummy, it may have already embedded and it's still an emergency. But once it gets stuck in the throat, that's where the problem comes about, right? And it can be very serious. So when you all have kids and your kid swallows one, what do you do? What do you do if your surgeon is busy with the 4-hour lap, or you're going to wait for a patient to go down to graze and things like that? So amazingly, there's a very good remedy for it. Honey. Good old honey. Amazingly. All right. Cools the battery, reduces the charge, reduces the risk of oxidation. No, I'm serious. There's some papers written about this, which I pointed out over here. All right. So that's one of the more recent papers that was done on it, but there's quite a few. All right. So it gives you an extra hour or two to remove that battery. So even if it happens here in hospital, we have honey around the hospital. We have a kitchen. Agreed. They may not have the best quality honey, but it's still honey. All right. So like I say, it just coats that battery and it just gives you that little bit of extra time. Like I say, you call Dr. Mani, good doctor, he'll come running. He'll also understand what the problem is, but he's busy with the gunshot. He can't leave the gunshot in theater and come running out to you, and he's still going to be there for 3 hours. You can't sit there and watch the kid get worse and worse and worse. All right. So you just put honey. Just get the kid to swallow honey. How much? 1 to 2 tablespoons. All right. Add another tablespoon if there's a burning sensation. So I know it sounds quite strange. We're not homeopaths. We are doctors. But this is actually a medically proven thing that it does help. All right. So like I say, we need the poo to the rescue. Okay. So it's an important thing to know. Just as generally as a doctor, you would also be called by family members, you'd be called by community members. What do I do? My kid swallowed this. And if you don't know about it, be like, don't worry about it, it'll pass. No. Listen, you know this is an issue now, all right? So you'll never forget it, okay? So, like I say, it's not an exhaustive presentation on the subject, all right? Just so you guys get used to seeing what soft tissue x-rays look like and what to look for, all right? So most conditions, especially soft tissue conditions, you have to do a CT to confirm it, all right? So most are potentially life-threatening and it's more prevalent in children, especially the infective parts, but injury parts can be with both, okay? So any change in the normal architecture should prompt further investigation. So to give an example, last week when you guys were here, we talked about internal decapitation, isn't it? Where C1 and the occiput, or basically the base of your skull and C1 dislocate. And the only thing that you'll find is just movement of the trachea forward. That's it. That's all that you'll see on an X-ray. But it is something that you must take note of, because otherwise you won't see anything. There's no fractures. There's nothing else going on, right? I'm not sure who any of you guys, or that's just a joke to finish off. But we had a patient who was beginning of the year, and we need to, I don't know if I should put up the videos as well, but we had a kid who was suffered a blunt trauma just to the front of the neck, all right? And actually had a crack on the trachea and then developed surgical emphysema, all right, around there. So what I'm going to do is I'm going to look for it on the Google Drive, and I'm going to post it again. You guys can just have a look at that, because it was quite a lovely one. It's a rare case. The first time I've seen it, in fact, and it was the first time that they had seen it here at Madadeni as well. So when this kid came in, all that he just had pain, bit of difficulty in swallowing. He was about 15 years old. So somebody had basically come and given him like a little karate chop at school. You know, they were playing around and somebody got a bit more angry than they were supposed to. And they just gave him a good karate chop. And it was like 3 days before. And now he had come, he was in pain, he wasn't feeling well, he was having difficulty. But when you looked at him, he's sitting over there, he's breathing fine. So they did the x-ray. Luckily, somebody did the x-ray. Then when we had a look at the x-ray, and you'll see it on there, there's all these streaks of gas, because quite simply the trachea had cracked open, right? And if you had left, and then when you go and you touch, you can feel that surgical emphysema underneath. You know, everything was happening. So I'll post that video again. So this patient ended up going to Grace, having quite extensive surgery, unfortunately, to repair the trachea. So it just shows you the importance of looking at this. Okay, so any questions? Anything I want to know? Not really. Completely understand the subject. Great. Okay. No, I'm just joking. What I'm saying, I know it's not exhaustive, but it's just to give you an idea of the normal, so that when you see the abnormal, you get the hang of it, right? So tomorrow we're going to cover a bit of toxicology again, and I'll post that video a bit later. Okay. Thanks, everybody. All right.